Ready? Okay, my name is Ben Scolati. I just got an order in from the doctor to do a mandible series. So I put into the computer a PA mandible, a Townes exaggerated mandible with a 40-degree caudate angle, and a left and right oblique lateral mandible. And I put in my patient's first name, last name, and date of birth. And I cleaned the vertical grid, and I'm all ready to go. And I have my IR 8x10. So I just have to get my patient now. Right this way, sir. So what is your first name, last name, and date of birth, sir?
Matthew Ryan, 3/20/1986.
Okay, what seems to be going on? What seems to be the problem?
I hurt my jaw. It was an athletic thing. I'm a world-class pie eater, and I just think I overdid it finally.
Oh, wow.
So it's been hurting a little.
Oh, that sounds fun. So we're gonna do a mandible series on you, okay? A couple, four views, all right?
All right.
All right, we're gonna get you a lead apron right here. Put this on backwards, actually. There we go. I know it seems so weird, but we're gonna do it backwards. And then sit in this chair right here that I have for you. All right, put your face the board right here. Now put your forehead and nose against the board. There we go. And I have dedented the tube transversely as well as lengthwise to 40 inches. Now the CR should exit the level of the lips because we're doing a PA mandible. So right there, and then place my marker on the right side right there, and then collimate, and it should be 8 by 10 inches is collimation. All right, and my technique would be 70 at 20. Stay just like that, sir. Beep. All right, now I've taken my picture. Now I'm gonna. You can relax, sir. I've taken my picture. Now I'm going to check this. I'm gonna scan it and then read it. I'm gonna do this with all of them, all of my exams. Here we have the PA mandible, and what we should see is the entire mandible, which we do, appropriate collimation, symmetric on both sides from the rami on the lateral side of the radiograph. And what this really does show is fragments from fractures and if it's displaced or not. The next one we're doing, we're going to have you go around. There we go. And now adjust your shield. Actually get up a little bit and adjust your shield to the left side. There we go, sir. Just to protect yourself. Keep going. That's all right. So now bring your right side as close to the board as you can. Bring your chin right there. Now what we need to do is have his head tilted 30 degrees towards the board because we're going to do a right side mandibular body radiograph right there like that. And then get my marker. It's the right side. Put it on. And now the CR should be have a 25-degree cephalic angle to it, and it should be entering between the mandibular bodies right there. Depress the shoulder because that sometimes gets in the way, so it's not in the way right here. So it's going up and right between the two bodies of there we go. And then adjust your IR a little bit higher because it's an angle, and bring it in closer just a wee bit. Bring it in because it's an axial right now. There we go. Right in between. There we go. So the technique would be 70 at 25 for this, the right side mandibular body. So I would take this, of course, I would leave the room and do it. And then I would take it, scan it, and read it. Here we have the right axiolateral oblique mandibular body in view. So the mandibular body of the right side is right here. and the left one is up here. Now there should be no superpositions of these two, as well as no foreshortening of the body or rami. And this criteria also fits for the left axiolateral oblique mandibular body projection. I'll come back here, put a new cassette, of course 8 by 10 lengthwise. And sir, I'm going to need you to get up and let's put this onto your right side. There we go. Perfect. Right here, sir. All right, now you're going to be facing me right now. There you go, sir. There we go. It was right up there, huh?
Alright.
Yeah. Okay, left side against the board. There we go. And then put your left marker. There we go. Put your left marker. There we go. Little bit, there we go, like that. Again, it's in between the two bodies of the mandible. I'm going to do decisioning, sir. There we go. Right about there. Left marker goes on, same thing, 70 kVp at 18 to 20 mass. I'll take this, beep. Scan, read, come back, and now 8 by 10 lengthwise. And now, sir, I'm going to have you stand up. All right, put this in the front of you. There we go. Good, good, sir. I'm going to bring this away so you have a little bit more room. Now you can put the back of your head on the IR right here, or the board right here. Just lean back if you can. Get nice and comfy. Now it's the, let's see, detented to 40. See? There we go. And now, it's an exaggerated towns. So, there we go. This tends to bring out the rami. It extends the rami. There we go. CR enters the glabella. Let's see, 40 degrees right there. All right, put my marker left side. I would go a little bit up on this technique because it's a diagonal radiograph. So I'd probably put 70 at 25. 70 kVp at 25 mass. Okay. Of course, I would leave the room and take the radiograph deep, and then I would check. Here we have the AP Towns exaggerated view of the mandible, and what's really in focus here is the rami of the mandible, and that's elongated, and what's supposed to be shown here is any fractures, sure, but also any fragments as well. All right, sir, we're all done with your mandibles. So
Can I eat my pie again?
we'll check with the doctor. If it's not too painful, of course you can, but
Okay.
you'll get results from the doctor within 24 hours, 1 day to 2 days. Okay. Have a good day, Mr. Ryan.
Alright.
Okay, my name is Ben Scalati. I just got an order in from the doctor to do a sinus series. So what we're doing is a Caldwell, a Waters, a lateral, and an SMB. Now I put in my patient's first name and last name and date of birth, and I cleaned the IR, and I cleaned the vertical grid, so we're all set to go. All right, I'm gonna go get my patient. Mr. Ryan, what's your first and last name and date of birth?
Matthew Ryan, 3/20/1986.
So what brings you in? What seems to be the problem?
I'm just all stuffed up right now. I don't know, my sinuses hurt.
Okay. All right, well, we're going to get 4 pictures. So I need you to stand right here, and I'll get a lead on right here. Right. Put it on backwards. There we go, sir. All right, sit on right down there. All right. see, forehead against the board. There. So I have my IR in. It's an 8 by 10 lengthwise. And now what I'm going to do is have the CR at the level of the Nasion. There we go. Put my marker. Column 8. All right. My technique for this would be maybe 70 at 25. Here we have a PA axial projection of the sinus, or a Caldwell method of the sinus, and what should be seen here is the petrous ridges superimposed the inferior, 1/3 of the inferior orbits and 1/3 of the inferior maxillary sinus. And what this projection primarily shows is the frontal sinus and anterior ethmoidal air cells. All right, sir, we're gonna get you on your left side right here. Put your head as close to the board as you can. There we go, and get it nice and straight. So what we have to have is the interpupilar line is perpendicular with the IR right here. There we go. Right there, sir. A little bit less rotation. There we go. Perfect. So my left marker goes on. There we go. My left marker goes on. There we go. Now the CR should enter 1/2 to 1.5 inches anterior to the EAM, the external auditory meatus. There we go. Of course, column 8. Technique would be 70 at 25, about 70 kbp at 25. I would take this, go out of the room, and then check this. Scan, read, and then on. Here we have a lateral projection of the sinus, and this happens to be a right lateral projection. So the point behind this one is to get all 4 sinuses in one projection. So here we have the frontal sinus. Here we have the ethmoid sinuses, and then here we have the sphenoid sinuses right here, and then here we have the maxillary sinus down here, and how we know we have no rotation with this one is that we have a couple anatomical structures superimposed on themselves. So here's the cell it should be superimposed on self. The frontal sinus behind that is the roof of the orbits. Those should be superimposed, the right and left orbital roofs, and that's how we know that there's no rotation. Alright, now time for the waters, the PA waters. So I'm going to have you stand up, sir. Alright, bring it around. There you go, on your buttocks. And now have your forehead against the board right here. Yes, good. Alright, now bring up your chin as far as you can. There we go. The point of this is bring the IOML 37 degrees that angle to the IR. There we go. And it should be exiting the cantillon. There we go. Bring the IR up a little bit. There we go. To level the cantillon. Column in a little bit. There we go. Just need the frontal from the top of the maxillary sinus to the top of the frontal sinuses, and then palmate side to side. There we go. Alright, take this, since it's diagonal, it's an axial, so I would go up on my technique a little bit, 70 to 25, 70 kbp, it's 25 mass. And I would take this beat, and then here we have a PA projection of the sinus, or Waters method, and what should be seen here is the frontal sinus all the way down to the
maxillary sinus. And what should really be in profile here is the foramen rotundum, which is right here. It should be at the medial floor of the orbit and the superior roof of the maxilla. And what should also be in profile is the petrous ridges, which should be at the most inferior part of the maxillary sinus.
Now time for my submandibular vertebral SMV projection. So I'm gonna have you stand up, sir. All right, bring in the shield around, and then place it on you. There we go. So shields your gonads. Sit back down again, and now put your back of the head against. There you go. And now bring the chair a little bit forward. There we go. And then lean your head backwards. Keep it. There we go. Perfect. You're doing fine. Let me if this hurts any. There we go. And now the CR. There we go. CR should enter 3/4 of an inch anterior to the EAM, the external auditory meatus. So right about that. Yep, that's perfect. All right, of course, collimate. There we go. Off to the left a little bit, sir. All right, there we go. I'll put my marker on the left side, and I'll shoot this at 70 kVp at 20 mass.
Here we have a submentovertical projection of the ethmoid and sphenoid sinuses. And what's shown here is the base of the skull, which also shows the ethmoid air cells right here on either side of the vomer, and also the sphenoid sinuses right here. And now how we know that there is no rotation is the mandibular condyles on both sides are equilateral to the radiograph, right here and right here. So we do have no rotation, and the mandibular protuberance should be superimposing the anterior frontal sinus. And there should also be mandibular condyles anterior to the petrous ridges. So those are higher than the petrous ridges, and the petrous ridges are right here on either side, and the condyles of the mandible are higher. That's how we know we have enough. The head is cocked back enough, and that there is no rotation.
All done, sir?
Alrighty.
I'll take that shield from you.
Alright, you have a lovely day, sir.
You too, and the doctor will get back to you in 1 or 2 days. My name is Vince Quality. I just got an order in from the doctor to do a orbit series, a PA, a Waters, and a single lateral rescue of the right orbit. So I have my patient's first name, last name, date of birth, and the projection set up, and I cleaned my vertical grid and IR, and the room is all set up, dedented to 40 inches, and longitudinally, and dedented to the grid transversely. Hello, sir. So what's your last name and first name and date of birth?
Matthew Ryan, 3/20/1986.
Okay, what seems to bring you in? What's the problem?
I don't know, my eye's hurting right here. I got hit in the face with a pie and it's been hurting ever since.
Oh, okay.
But yeah, it's a bit sore.
You wouldn't think a pie would hurt, huh?
Well, it must have been the tin, I think.
Oh, okay. Well, we'll get you in this seat right here right after we put a lead on you. There we go, sir. And now bring it around the back, actually. There we go. All right, sir, watch out for the tube. There we go. All right, put your forehead and nose against the board right there. There we go. I'm going to put my right mark right there, and now I'm going to center at mid-orbit, which is about the nasion right there. So I'm going to bring up the board right there, sir. Go. Same thing with the IR, or the tube. And you're not pregnant, are you, sir?
Nope.
Okay. All right, collimate a little bit. Now what this tube right here, the collimating tube, does is reduce scatter. So that's what I have the orbit for. So keep it just like that. And my technique would be 65 kVp at 20 mass. All right, I would take this deep.
Here we have a PA projection of the orbits, and it's a cone down. And why this is important is to look for any fragments or any particles within the eye or within the orbit, and also to make sure to have one orbit or eye as reference to another, to make sure that there is no abnormalities. And what we should see is the Petrus ridges in the lower 1/3 of the orbits.
All right, for this image, I'm going to have you put your chin way up. Yep, as far left as you can. So the point of this is to bring the IOML at 50 degrees to the IR. And let's see. Off to the right a little bit. There we go. Collimate to both sides. You want to get both sides just for the doctor to have a reference point. So to compare the two left and right sides of the orbits. So put your marker, that's my right marker on there on the right side. Alright. It's at the level of mid-orbit or the nasion. And I would take this at a little bit higher. So it would be 70 kV at 25 mass. Because it's going through more matter. Okay, beat of course, and then I would take this, scan it, and read it, and if it's good.
Here we have a PA projection of the orbits during a water method, and what we have here is the Petrus ridges lying way below, far below the as well as the maxillary sinus, so there's no superposition of them whatsoever, and there is no rotation. How we know this is that the lateral sides of the skull are equidistant to the lateral lateral sides of the radiograph, and it's a closed beam restriction, so it's a cone down of both of them. And again, this is to have reference for one or the other.
I'll come back here and do my last one, which is the 3-point landing Reese method. So I would, sir, could you put your right side, yep, right side against the board right there. Now what the point about this is put the cheek, the chin, and the nose. So we're gonna have your cheek, nose, and chin against the board, make it a plane. Right, move off to the right a little bit, and this time it's unilateral, so one-sided, not both sides, not bilateral. Put your marker, right marker, there we go, and it'll be pretty much the same of the technique as the waters, because it's diagonal through the head. So you would put 70 kVp at 25 mass, and I'll of course check my R and read it.
All right, what we have here is a PA of one orbit, and it's the Reese method. And what's majorly in profile here is the ethmoid air cells right here, and that's to make sure that there's no fragments in it from a fall or accident, or from an infant shoving something up their nose. And then there's optic canal right there, the superior orbital fissure, and then there's also of the sphenoid right here. And
all right, sir, we are done.
All right, thank you.
You're welcome. Watch the tube right there.
Oh.
Yeah, it's a little bit close. Okay, you'll get word from the doctor in 1 or 2 days.